Imagine a patient sits down in your clinic, looks you dead in the eye, and tells you with, absolute terrifying sincerity that the television in the waiting room is transmitting static directly into their teeth.
Right, a very intense presentation.
Exactly. So do you write that down verbatim, or do you translate it into neat medical terminology? Like, do you just write patient presence with somatic delusions? Today, we are opening up Kaplan and Sadok's comprehensive textbook of psychiatry, specifically Chapter 7.2, to decode the actual mental algorithms psychiatrists use when they are faced with precisely that situation. We are doing a deep dive into the psychiatric report and the outline for a psychiatric examination.
Yeah, and the problem with just writing patient presence with somatic delusions is that it entirely erases the specific architecture of the patient's psychosis.
It totally sanitizes it.
Right. If you were a trainee, a registrar, or simply someone trying to understand how clinicians actually think, the first lesson of this text is that observation only becomes understanding when it is organized into a coherent story.
Which is the core of the whole thing, really.
Absolutely. Because psychiatry is the study of how the brain, the mind, and human experience interact. And crucially, how that intricate process can go wrong. When a patient sits across from you, they are not handing over a neat chronological blueprint of their distress.
No, they're definitely not.
They are offering fragments, just raw pieces of information.
So put yourself in the shoes of the clinician. Gathering a patient's symptoms during an interview, like the sleeplessness, the anxiety, the strange thoughts about the television, it's like being a cartographer plotting totally random coordinates on a blank piece of parchment. It is just raw data.
Yes, just dots on a page.
But the psychiatric report itself, the actual document and the thought process underpinning it, well, that is the map. It is the mechanism through which raw observation becomes clinical understanding.
It allows you to actually navigate a patient's mind.
Right. But let's start by establishing what this document actually represents in the broader medical world.
Functionally speaking, the psychiatric history and the mental status examination, or MSE, they are to the psychiatrist exactly what the medical history and the physical examination are to the internist.
I love that analogy. It grounds it perfectly.
It does, right? Think about how an internist works. They listen to your heart for murmurs, they palpate your abdomen, they tap your knees to check reflexes. The psychiatrist is doing the exact same thing, but, their instruments are different.
Because they're looking at different systems.
Exactly. The psychiatrist listens to your speech patterns for pressure delivery, they test your memory, they assess your capacity for abstract thought.
So the internist checks the physical hardware, and the psychiatrist is checking the software. And I guess often how the hardware is actually running that software.
That's a brilliant way to phrase it. And the textbook refers to the psychiatric history by a very specific clinical term, which is anamnesis.
Anamnesis, which is Greek for to remember, right?
Yes. It captures the essence of the psychiatric history perfectly because it describes an active process. The history attempts to describe life events from infancy all the way to old age, well, to the extent that they can be recalled.
So it's not just a passive list.
Not at all. It is not just a chronological list of jobs held and addresses lived at. It is the active process of the patient recalling and reconstructing their life narrative, guided by the clinician.
Wait, I have to challenge that premise a bit.
Sure, go ahead.
If the ultimate goal is anamnesis, like gathering all these memories and symptoms as accurately as possible, how does the psychiatrist avoid just becoming, a highly paid court stenographer?
That's a very fair question.
Because if the patient says, I have been sad for 2 weeks and I cannot sleep, and the clinician just writes that down, that is mere transcription. Where does the actual clinical expertise come in?
Well, a court stenographer records everything without judgment. They're just a passive receptacle for data. The psychiatrist, on the other hand, must actively distill and interpret that information.
Right, they have to filter it.
Exactly. The report is much more than the history and the mental status combined. For example, facts alone do not create understanding. The report must include a summary of positive findings, what is actively present, but, just as importantly, it must highlight negative findings.
The things that are missing.
Yes, what is notably absent.
So if you are evaluating a patient who is profoundly depressed, they've stopped eating, and they cannot get out of bed, but you specifically note that they lack suicidal ideation, that absence is a critical negative finding.
Completely. It changes the immediate triage protocol entirely.
I see.
Furthermore, the report has to address critical clinical questions that the raw data provokes. Based on this history of, say, sudden onset anxiety and a strange metallic taste in the mouth, Do we need an electroencephalogram, an EEG, to rule out a temporal lobe seizure disorder?
Oh, wow, right, because it might not be psychiatric at all.
Precisely. Or are psychological tests indicated to clarify whether a patient's difficulty at work is due to a personality structure issue or maybe an underlying intelligence baseline deficit?
It's all about interpretation.
Yes. The report is the bridge between raw observation and clinical judgment. It demands an interpretation of the data.
So the map isn't just the terrain, it is the legend, the scale, and the recommended route all in one.
That is spot on.
Having established that, let's look at how the clinician travels back in time to gather this raw material. We are diving into the psychiatric history section of the text, systematically looking at biological and environmental mechanisms.
And it begins with identifying data and the chief complaint, or CC.
Right.
Demographic data sets the immediate epidemiological stage. But the chief complaint is critical because, returning to your opening example about the television, the text strictly advises that the chief complaint must be recorded in the patient's own words.
Not translated into jargon. You write exactly what they say.
Exactly.
Yeah.
The clinical reasoning there is immediate. A bizarre verbatim complaint points straight toward a psychotic process before you have even asked your second question.
That makes a lot of sense.
If you translate it to somatic delusions, the next doctor who reads the file doesn't know if the patient thought they had a parasite or if they thought the CIA was beaming radio waves into their dental fillings.
And the specific mechanism of the delusion really matters.
It absolutely matters.
From there, the clinician moves into the history of present illness, the HPI, and the past history. And this is really about tracking the chronological development of the symptoms, right?
Yes. You want to know what the life circumstances were when this started? What was their personality like when they were well?
And the text makes a major point about the onset timeline. Like, sudden onset should set off massive alarm bells.
Huge alarm bells.
Yeah.
In psychiatry, most classic idiopathic disorders, meaning conditions that arise spontaneously from within, like a major depressive episode or the insidious, slow onset of schizophrenia they take time to build.
They have a build-up phase.
Right. They have a prodromal phase.
Yeah.
If a patient goes from perfectly functional to floridly psychotic or intensely manic over the course of a single weekend, your clinical reasoning should instantly pivot to exogenous factors.
Outside forces.
Exactly. Sudden onset highly indicated drug-induced disorders, an acute neurological event like a stroke, or delirium caused by a systemic infection.
Which explains why the psychiatrist acts so much like the internist during the past history section.
Right, they are checking for medical conditions.
Yeah. Craniocerebral trauma, loss of consciousness, seizures, even looking at vaccination history like DPT, influenza, or COVID, because systemic inflammatory illnesses can manifest psychiatrically.
They absolutely can.
But I want to take you deeper into the timeline. The family and personal history spanning from infancy to adulthood. Think of this like inspecting the roots and the soil of a tree rather than just looking at the wilted leaves on the branches.
That's a great visual. And the soil contains profound biological and genetic mechanisms. The textbook highlights specific, measurable risks that are entirely developmental.
Okay, let's unpack that.
Let us examine parental age at birth. The medical community has long understood that older mothers, specifically over 35, carry a known higher risk for having a baby with Down syndrome due to meiotic non-disjunction in the ova.
Right, that's pretty widely known.
But the text points out something equally critical regarding older fathers. Fathers over the age of 75 have an increased risk of contributing damaged sperm-producing deficits.
Explain the mechanism behind that. What does an older father's sperm actually manifest as psychiatrically in the offspring?
It manifests as an increased risk for schizophrenia.
Wow, really?
Yes. To understand why, you have to look at the cellular level. In females, all ova are formed before birth. They sit in a state of suspended animation.
Okay.
But the spermatogenesis process in men involves continuous cell division, mitosis, throughout the man's entire life. By the time a man is 45, his spermatogonial stem cells have divided hundreds of times more than a 20-year-old's.
Oh, I see. So there's more room for error.
Exactly. Every single time a cell divides, there is a tiny statistical chance for a copying error in the DNA. Over decades, these errors accumulate.
What are those called?
We call these de novo mutations, new mutations that were not present in the father's own genetic code. These accumulated mutations increase the polygenic risk for complex neurodevelopmental disorders, like schizophrenia in the child.
That is incredible. So the psychiatric history isn't just asking, is your dad crazy? It is asking, how old was your dad when you were conceived? Because the biology of cell division informs the psychiatric risk profile.
Precisely. It is all connected.
And of course, the clinician looks heavily at genetic loading in the family history for anxiety, depression, and bipolar disorder. Because if a first-degree relative has bipolar disorder, the entire context of a patient's presenting depression changes.
It changes everything. You have to be incredibly careful prescribing an antidepressant in that scenario.
Because you might flip them into a manic episode.
Exactly. That is a perfect example of applied clinical reasoning. The history directly dictates the pharmacological intervention.
Let's follow the timeline forward into childhood manifestations, because this part of the text really demands a second look. First, it states that childhood memories before the age of 3 are almost always imagined.
Yes, that often surprises people.
Right. They are not actual episodic memories. They are collaborative fictions we have internalized from photographs and family lore. But then it links very specific childhood behaviors to adult pathologies.
The mechanistic links between childhood behavior and adult psychopathology are vital. For example, the textbook notes that separation anxiety and school phobia in childhood are strongly associated with adult depression.
Why, though? Why does being scared of school turn into clinical depression 30 years later?
It comes down to the underlying neurobiology of threat detection and attachment insecurity.
Okay.
A child with severe separation anxiety often has an overactive amygdala and an underdeveloped regulatory pathway in the prefrontal cortex.
So their fear center is just too loud.
Yes. They experience routine separation as a catastrophic threat. Now, as the brain matures, the environment changes. But that underlying physiological vulnerability, that tendency for the nervous system to become overwhelmed and depleted by stress, remains.
It just shifts form.
It simply changes its clinical presentation. The exhaustion of chronic anxiety often transitions into the anhedonia and low mood of adult depression.
The textbook also highlights enuresis bedwetting beyond an appropriate developmental age. And it associates this with fire setting and other significant behavioral disturbances.
Yes, it does.
For the listener, this sounds a lot like the McDonald triad, the old criminological theory about serial killers. Are we saying bedwetting predicts psychopathy?
We need to be very precise here to avoid sensationalism.
Good point.
It is not that bedwetting creates a psychopath. Rather, enuresis, fire setting, and cruelty to animals are all diverse manifestations of a single underlying mechanism, which is profound behavioral dysregulation and delayed neurodevelopment.
So it's a structural issue.
Exactly. A child who cannot exert neurological control over their bladder at an older age is often demonstrating a broader delay in the frontal lobe's ability to exert inhibitory control over impulses.
Oh, and fire setting is an external manifestation of that same lack of impulse control.
You've got it. The psychiatrist is looking for patterns of systemic regulatory failure, not just isolated bad habits.
That makes total sense. Moving into adolescence, the text points out that poor school performance is a highly sensitive indicator of emotional disorder.
It really is.
Because if a previously straight-A student suddenly starts failing their exams, the clinician cannot just assume laziness or teenage rebellion.
No, a sudden drop in academic performance is a systemic failure.
Okay.
The cognitive bandwidth required to excel in school is immense.
It takes a lot of mental energy.
Right. And if that bandwidth is suddenly hijacked by the onset of a major depressive episode, illicit substance abuse, or the prodromal phase of schizophrenia, which classically begins in late adolescence or early adulthood, the grades will be the first thing to collapse.
So it's an early warning system.
Exactly. The school report card is often the earliest objective biological marker of a psychiatric illness.
Which brings us to adulthood and sexual history, examining work, marriage, religion. The textbook gives brilliant advice on the actual strategy of clinical reasoning here, specifically how you ask the questions.
The phrasing is everything.
Right. There is a massive psychological difference between asking a patient, "Did you ever masturbate?" versus asking, "When did masturbation begin?"
That is a fundamental interviewing technique.
Yeah.
By asking, "Did you ever?" you are subtly implying that the behavior is optional, aberrant, or perhaps something shameful that requires a confession.
It feels accusatory.
It does. It instantly raises the patient's psychological defenses and invites a defensive no.
Right.
But by assuming normalcy and asking, "When did it begin?" you remove the stigma. You communicate to the patient that this is a standard human behavior, you expect it, and you are simply collecting the chronological data.
It bypasses the shame reflex.
Exactly. And it yields far more accurate anamnesis.
So we have traced the longitudinal timeline. We have the history, the roots of the tree. Now we transition from the past to the cross-sectional snapshot of the patient sitting in the room with us right now. This is the mental status examination, the MSE.
If the history is the documentary of the patient's life, the MSE is a high-resolution photograph taken in the exact moment of the interview.
I like that.
It is the sum total of the examiner's real-time observations, beginning with appearance and motoric behavior.
And to be clear for the listener, this isn't just a casual fashion check. It is rigorous forensic observation.
It has to be.
Yeah.
Are they unkempt and disheveled? That might point to a cognitive disorder like early-stage dementia, where the executive function required to sequence getting dressed has failed.
Where they just don't have the energy.
Right. It could be severe depression, where the sheer energy required for self-care is collapsed. You must observe their physiology.
Like their eyes.
Yes. What about their pupils? Pinpoint pupils should immediately make you suspect narcotic addiction or intoxication, overriding whatever psychiatric symptoms they're reporting.
And smell is a big one, too.
Absolutely.
Mhm.
What do they smell like? A smell of alcohol is obvious, but a fruity acetone smell could be diabetic ketoacidosis.
And ketoacidosis can cause altered mental status that perfectly mimics a psychiatric illness.
Precisely. If a patient's in a diabetic crisis, they might appear confused, agitated, or even delirious. If a psychiatrist fails to smell the acetone and assumes it's just a panic attack, that patient could slip into a coma.
That's terrifying.
Yeah.
Let's talk about eye contact, because here is where I really need to push back on the text a bit.
Good for it.
I think most people assume normal eye contact is 100%, just staring attentively at the person talking. The text specifies that 50% eye contact is actually normal, but isn't that incredibly subjective?
It is subjective, yes.
Because if a patient is from a cultural background, say certain Asian or indigenous cultures where looking an authority figure directly in the eye is considered highly disrespectful, a psychiatrist rigidly applying this 50% rule might falsely document poor eye contact and misdiagnose them with depression or paranoia. Does the text account for that?
That is a vital critique. The 50% metric is a baseline for Western neurotypical conversation, where continuous, unbroken eye contact is often perceived as hostile or predatory, and normal conversation involves looking away to process thought.
Right, you look away to think.
Yes. However, clinical reasoning dictates that the MSE must be calibrated to the patient's cultural and baseline norms. If a patient is avoiding eye contact out of cultural respect, their body language will likely be calm and deferential.
But if it's pathology...
If they are avoiding eye contact due to the profound psychomotor retardation of severe depression, their gaze will be fixed downward, accompanied by a heavy, leaden posture.
And what if they are constantly scanning the room, like looking at the door, the window, the corners of the ceiling?
That hypervigilance strongly suggests paranoia. They are actively searching the environment for perceived threats. The eye contact isn't just a metric. It is a window into where the patient's attention is focused inward on their own distress or outward on potential danger.
Then there is the patient's attitude towards the examiner. The text introduces some classic, almost poetic terminology here, like seductive behavior might point to a histrionic personality structure. But I want to dive into la belle indifference.
La belle indifference. It translates from French as the beautiful ignorance or the beautiful indifference. It is classically associated with conversion disorder.
Which falls under the umbrella of functional neurological symptom disorders.
Correct.
Explain the mechanism of conversion disorder, because to a layperson, it sounds like the patient is just faking it.
I'm glad you brought that up, because it is absolutely not faking. Malingering is faking a symptom for secondary gain, like getting out of work or getting a prescription.
Right.
Conversion disorder is an unconscious process where overwhelming psychological stress is converted into severe physical neurological symptoms like sudden blindness, non-epileptic seizures, or the paralysis of a limb.
That's incredible. How does that happen?
The mechanism is fascinating. The brain, unable to process a massive emotional trauma, essentially trips a circuit breaker. The limbic system, which processes emotion, exerts an inhibitory effect on the motor or sensory cortex.
So the brain physically shuts down the limb to avoid processing the unbearable affect.
Yes. The blindness or paralysis is entirely real to the patient.
But where does the indifference come in?
What is striking to the examiner is the attitude. A normal person who suddenly goes blind is terrified. They're panicking in the emergency room.
Obviously.
But a patient with conversion disorder might describe their sudden, profound paralysis with a striking, eerie apathy. They are indifferent to their own severe symptoms because the symptom itself has successfully relieved the underlying psychological anxiety.
That is a wild mechanism. The symptom is the cure for the anxiety, so they aren't bothered by the symptom.
Exactly.
And then there is another classic term from the text, Witzelsucht.
Witzelsucht is a neurological term, originally German, for an inappropriate, uncontrollable tendency to make puns, tell inappropriate jokes, or tell pointless stories at highly inappropriate times.
And what does that indicate?
It strongly indicates frontal lobe syndromes.
I always think of the frontal lobe as the brain's social bouncer.
That is exactly what it is. The prefrontal cortex provides inhibitory control over our impulses. It stops you from laughing at a funeral. It filters your thoughts before you speak.
Right.
When that area of the brain is damaged by a tumor, blunt force trauma, or frontotemporal dementia, the bouncer leaves the building. The filter vanishes, and the patient cannot stop themselves from making the inappropriate pun.
Let's move on to speech, mood, and effect. I want to use an analogy here to clarify the textbook definitions because it is so easy to confuse mood and effect.
It really is a common point of confusion.
So think of it like meteorology. Mood is the climate. It is the pervasive, sustained emotional baseline over a long period of time, like global warming or a long, bleak winter. Effect is the weather. It is the outward, momentary expression you see right now in the room, like today's sudden rain shower or brief ray of sunshine.
That distinction is critical for the MSE. A patient can have a deeply depressed mood, a cold, bleak climate. But if the psychiatrist tells a joke, the patient might momentarily smile, showing a reactive effect, a brief ray of sunshine.
So they can coexist.
Yes, and in the MSE, we must evaluate both independently. Now, for speech, we listen for pressured speech, which is a hallmark of mania.
What does pressured speech actually sound like? Is it just talking fast?
No, it is not just talking fast. It is a relentless, driven torrent of words. The patient feels an intense internal pressure to speak, often talking over you, unable to be interrupted.
They physically can't stop.
Right. The words tumble out faster than the physical mouth can articulate them, because the brain's ideational pathways are in overdrive. On the opposite end, we look for a positive speech, seen in severe depression, where every word requires immense physical effort.
The text also mentions listening for prosody. What is that?
Prosody is the musicality, the emotional intonation, and the rhythm of natural speech. When you ask a question, your pitch goes up at the end.
Sure.
A lack of prosody sounds flat, robotic, and monotone. A complete loss of prosody can indicate severe cognitive disorders, certain presentations on the autism spectrum, or catatonia.
So how does a psychiatrist use these observations to actually separate one diagnosis from another? What is the clinical reasoning there?
The textbook provides critical diagnostic markers, particularly regarding physiological functions like sleep.
Sleep is a big indicator.
Huge. Both a severely depressed patient and a manic patient might present to the clinic reporting they only sleep 3 hours a night. The data point is the same.
But the reasoning is different.
Exactly. The clinical reasoning lies in the why and the subjective experience. A depressed patient experiences early morning awakening. They are exhausted, they desperately want to sleep, but their brain forcefully wakes them up at 3 a.m. in a state of autonomic distress and rumination. They are suffering from the lack of sleep.
And the manic patient?
A manic patient has a decreased need for sleep. They sleep 3 hours, wake up at 2 a.m., and feel fully rested, energized, and ready to start a new business or repaint their house.
That's a huge difference.
The neurobiology of sleep architecture in depression involves disrupted REM pressure and hypercortisolemia. In mania, the entire circadian rhythm is overridden by hyperarousal. The subjective experience of the symptom differentiates the diagnosis entirely.
Another marker the text highlights is inappropriate effect.
Yes. If a patient is smiling broadly and laughing while describing the recent tragic, violent death of a loved one, that profound mismatch between the thought content and the emotional expression is a hallmark of schizophrenia.
It's like the wires are crossed.
The internal thought process has become disconnected from the emotional regulation centers.
And crucially, under the mood section, the textbook mandates that we must assess suicide. It notes that suicidal ideation is present in 25% of depressives. It is a stark statistical reality.
It really is.
You cannot just wait for the patient to bring it up. The psychiatrist must explicitly ask about it to document that negative or positive finding.
Absolutely essential.
Moving into section 4, integration and clinical reasoning. We are going deeper into the brain's machinery now. We have looked at the history and the outward behavior. Now we are testing the internal cognitive hardware. We are looking at thinking, perception, and the sensorium.
We must divide this into the form of thinking and the content of thinking. Let us start with perception, specifically hallucinations.
Okay.
Hallucination is defined as a sensory perception in the absence of an actual external stimulus. But the sensory modality, whether the patient is seeing, hearing, feeling, or smelling things, provides massive clues to the underlying etiology.
Most people associate hallucinations exclusively with schizophrenia, like hearing voices.
Auditory hallucinations are indeed the classic symptom of schizophrenia. The neuroanatomy involves the superior temporal gyrus, the area responsible for auditory processing.
So what's happening in the brain?
In schizophrenia, the brain generates internal monologue or thoughts, but a functional disconnect occurs, and the brain misattributes those internal thoughts as external voices coming from outside the head.
But what if the patient is seeing things? If they see people standing in the corner of the room, why isn't that schizophrenia?
Visual hallucinations strongly suggest a primary medical or neurological issue or a severe drug intoxication, rather than a primary psychiatric illness.
Oh, really?
Yes, the visual cortex at the back of the brain is highly susceptible to metabolic derangements. If an elderly patient is suddenly seeing small animals or silent people in the room, your clinical reasoning should immediately pivot to delirium caused by a urinary tract infection or the onset of Lewy body dementia. You look for a medical cause first.
That is such a vital distinction. And what about tactile or haptic hallucinations, feeling physical things on the skin?
This is highly suggestive of severe substance abuse or withdrawal. Specifically, the sensation of bugs crawling under the skin, a phenomenon called formication, is classically seen in severe cocaine abuse or in delirium tremens, the life-threatening state of alcohol withdrawal.
Explain the mechanism of delirium tremens, or DTs. Why does alcohol withdrawal make you feel bugs under your skin?
It is a rebound effect. Alcohol is a central nervous system depressant. It heavily stimulates GABA, the brain's calming neurotransmitter.
Okay, so it slows everything down.
Right. If a person drinks heavily for years, the brain downregulates GABA receptors and upregulates glutamate, the excitatory neurotransmitter, just to maintain a baseline balance.
It's trying to find equilibrium.
Exactly. Now, if that person suddenly stops drinking, the alcohol is gone, but the brain is still flooded with hyperactive glutamate receptors. The nervous system becomes massively hyperexcitable.
So it just goes into overdrive?
Yes. It starts misfiring spontaneously, sending signals to the sensory cortex that register as intense crawling sensations on the skin. It's a neurological emergency, not a psychiatric one.
That perfectly illustrates why the sensory modality acts as a compass. What about olfactory hallucinations? Smelling things like burning rubber or phantom foul odors?
The olfactory bulb is located right next to the temporal lobe. Phantom smells strongly point toward a neurological lesion, a tumor, or seizure activity, specifically in the temporal lobe. It is often an aura preceding an epileptic seizure.
So we have perception sorted. What about thought content, specifically delusions? A delusion is a fixed false belief that is resistant to reason or contrary evidence.
Yes, and the psychiatrist has to evaluate how that delusion relates to the patient's mood. We categorize delusions as mood congruent or mood incongruent.
Give me an example of mood congruent.
If a patient is in the grip of a manic episode, feeling elated, energetic, and powerful, and they develop a delusion that they are a secret billionaire who has discovered the cure for all diseases, that is a mood congruent, grandiose delusion.
Right, the content of the delusion makes logical sense within the elevated climate of their mood.
Exactly.
But what if they are deeply depressed, like they haven't eaten, they feel worthless, but they have a grandiose delusion that they are an all-powerful deity?
That is mood incongruent. There's a total disconnect between the profound depression and the grandiosity of the belief. Mood incongruent delusions are a major diagnostic pivot.
Where do they point?
They strongly point away from a pure mood disorder and point towards schizophrenia or schizoaffective disorder.
The text also highlights thought insertion, the terrifying delusion that outside forces, like the government or aliens, are literally placing foreign thoughts into the patient's mind against their will.
Yes, this is considered a first-rank symptom, heavily characteristic of the boundary loss typical in schizophrenia.
Then we have thought process. This isn't about what they are thinking, it is about how the thoughts connect together in real time.
Exactly, the structure of the thought. We look for loose associations versus flight of ideas.
What are loose associations?
Loose associations represent a fundamental failure of logical connection between concepts. A patient might say, I went to the store. The color blue was very aggressive. My mother hated Tuesday.
There is no causal or linguistic link between those sentences.
Right. The associative threads have snapped. This points heavily to schizophrenia.
And how is flight of ideas different? Because to a layperson, that also sounds like jumping around randomly.
Flight of ideas is different because the associative threads are still there, But they are hyper-accelerated and often connected by superficial things like puns, rhymes, or immediate environmental stimuli.
Okay, so there is a thread, it's just very thin.
Yes, patient might say, I went to the store. The store has doors. Doors, floors, chores. The government is doing chores. The ideas are connected by rhyming sounds clanging, but they come at a blistering, unstoppable pace. That structure points to mania.
This brings us to sensorium and cognition testing. This feels the most like the neurologist's domain. We are checking alertness and orientation, specifically orientation to time, place, and person.
If a patient is delirious due to an infection or has advanced dementia, their sensorium is clouded. And the textbook notes there is a predictable biological pattern to how orientation is lost.
What goes first?
Orientation to time is almost always the first to go. The brain loses its temporal anchor. Then orientation to place is lost. They don't know they are in a hospital.
And what about person?
Orientation to person, knowing who they are, their own name remains intact much, much longer.
So if a patient comes into the emergency room, knows the exact date, knows they're in a hospital in London, but claims they have absolutely no idea what their own name is, what do you think?
You should be highly suspicious. Losing identity while retaining time and place is the reverse of normal organic brain decay.
So what is it then?
It points toward a dissociative disorder, a psychogenic fugue state, or malingering faking amnesia to escape a legal or financial crisis.
Let's delve into memory testing. Remote, recent, and immediate. The text gives a fascinating detail about Alzheimer's disease. Patients retain remote memory events from their childhood much longer than recent memory, like what they had for breakfast.
Yes, the temporal gradient of memory loss.
But I want to present a clinical challenge here. You are a doctor. An 80-year-old man is brought in by his daughter. The daughter says his memory is gone. He can't remember anything I tell him. How do you know if it is a real organic brain disease like early dementia, or if it is just an elderly man who is severely depressed, highly anxious, and therefore just not paying attention to his surroundings?
That is one of the most critical differentials in geriatric psychiatry. It introduces the concept of pseudodementia.
Pseudodementia.
Right. Severe depression or anxiety can perfectly masquerade as memory loss. The cognitive bandwidth of the patient is so entirely consumed by their internal distress and rumination that they simply aren't registering new information. The memory isn't broken. The attention mechanism is offline.
So how do you test the difference in the...
True organic brain disease has a distinct clinical signature. Amnesia almost always hits recent memory before remote memory, and the patient's reaction to their deficit is telling.
How so?
If you ask the depressed man with pseudodementia who the prime minister is, he will often give an exasperated, I don't know answer. He will show great distress about his poor memory and simply give up on the cognitive task because of low energy.
And the patient with true early dementia.
A patient with true early dementia will often try to hide the deficit. They will confabulate.
Confabulate?
Yes, confabulation is not lying.
Yeah.
It is the brain's unconscious attempt to fill in the missing gaps of memory with plausible, fabricated stories to maintain social grace.
Oh, that's fascinating.
If you ask them who the prime minister is, they might smile and say, oh, it's Churchill. Saw him on the wireless just this morning.
They're often pleasantly unaware of the profound extent of their deficit. That distinction between I don't know and confabulation changes the entire diagnostic trajectory. To test concentration and abstract thinking, the MSE uses the serial sevens test, asking the patient to subtract 7 from 100 sequentially. And then we ask them to interpret proverbs, like, people in glass houses shouldn't throw stones. Why proverbs?
The proverb test is a beautiful, rapid window into the frontal lobe's ability to conceptualize and abstract. A healthy adult will process the metaphor and give an abstract answer dealing with universal moral themes. It means don't criticize others for faults you also possess.
But a patient with severe schizophrenia or perhaps traumatic brain damage.
They will often give a highly concrete answer. They will reply, because the stone will break the glass and you'll have to pay for it.
They miss the metaphor entirely.
Completely. They cannot extract the metaphorical universal meaning. Their cognitive process is trapped in the literal, physical properties of the words themselves. It is a profound failure of abstract reasoning.
Finally, in the MSE, we assess insight and judgment. An insight isn't just a binary yes or no question, do they know they are sick? The text actually maps insight out on a 6-point spectrum.
Yes, moving from complete, rigid denial of the illness to slight awareness, but blaming it on outside factors or physical ailments.
And
then we reach a fascinating, frustrating stage called intellectual insight. This is where the patient fully admits they are ill. They recognize their symptoms, their paranoia, or their addiction is irrational and destructive.
Hmm.
But they completely fail to apply this knowledge to alter their behavior.
They know the stove is hot. They can explain the thermodynamics of the stove to you perfectly, but they keep putting their hand on it anyway.
Exactly. The cognitive understanding is isolated from the behavioral execution. The ultimate goal of psychiatric therapy is to move them to the final stage, true emotional insight.
Where it all clicks.
Yes. This is where cognitive awareness integrates with emotional resonance, actually leading to lasting changes in personality structure and future behavior.
Wow. Okay, we have the history. We have the mental status examination. We have analyzed the cognitive hardware, the memory, the insight. Now we arrive at section 5, the final synthesis. We have to formulate this massive collection of data into the coherent story we talked about at the very beginning.
This is the psychiatric report.
This is where it all comes together to inform clinical care and critically legal and administrative processes.
The synthesis begins with the formal diagnosis, classified according to the current DSM and the prognosis, weighing the biological and social protective factors against the risk factors to predict the future course of the illness.
But the real intellectual art of the report is the psychodynamic formulation.
Absolutely. This is where the clinician determines the why. Why did this specific patient with this specific genetic background suffer a psychological breakdown at this specific time in their life?
It incorporates the environmental triggers, the genetics, the primary and secondary gains of being ill, right?
Yes. And the unconscious defense mechanisms at play. Are they managing their anxiety through projection, paranoid denial, or rigid intellectualization? The formulation explains the functional reality of the patient to the entire treatment team.
Which leads directly into the comprehensive treatment plan.
Exactly. This outlines the specific psychotherapy modality, the targeted psychopharmacological medications, and the therapeutic team approach involving social workers, nurses, and clinical psychologists.
But the textbook doesn't shy away from the harsh clinical reality of the job. The psychiatrist has to assess life-threatening situations.
They do. The report must explicitly and thoroughly document the assessment of suicidal risk or the danger the patient poses to the public.
That's a huge responsibility.
It is. These are the specific medical and legal criteria that justify involuntary hospitalization or sectioning. The psychiatrist's documentation literally has the power to deprive a citizen of their liberty in order to save their life or protect society. The ethical and legal weight of that responsibility is immense.
Which perfectly explains why the text places such heavy, almost pedantic emphasis on the precision of writing in the report.
Precision is everything.
The textbook explicitly mandates clarity. It says, avoid run-on sentences. Use the active voice. And it gives a great example of what not to do. It says writing, patient denies hallucinations and delusions, is poor medical writing.
It is poor because it is vague, lazy, and relies on sweeping jargon. Did you ask them about visual hallucinations? Did you ask about olfactory?
Right.
The text advises writing. Patient denies hearing voices or thinking that he is being followed. That is precise.
That leaves no room for guessing.
Exactly. It tells the reader whether that is a psychiatric nurse taking over the night shift or a high court judge reviewing an involuntary hold, exactly what specific question the psychiatrist asked and exactly what the patient responded to.
Effective reports avoid unnecessary complexity. They aren't trying to sound like a philosophy dissertation. They are trying to be perfectly, unbreakably clear. They communicate the clinical reasoning pathway, not just a list of findings.
That's on.
Okay, we have covered an immense amount of ground, from cellular mitosis to legal documentation. I want to reinforce this learning. Instead of just reading out a quiz, let me give you, the listener, a few clinical scenarios based strictly on the text we just explored. I am going to set up a situation, pause briefly so you can lock in your clinical instinct, and then we'll break down the rationale.
Sounds good.
Scenario 1. You are taking a family history. You note that the patient's father was 48 years old when the patient was conceived. Based on the mechanism of continuous cell division and de novo mutations in spermatogenesis we discussed, this older paternal age increases the genetic loading for which specific psychiatric condition. Take a second to think.
The answer is schizophrenia. While older maternal age is linked to chromosomal non-disjunction issues like Down syndrome, older paternal age increases the risk of subtle genetic copying errors over decades, contributing heavily to the polygenic risk for schizophrenia.
Scenario 2. A patient presents to your emergency clinic in a state of panic, reporting an intense phantom smell of burning rubber. Before you even consider a primary psychotic disorder like schizophrenia, Your clinical reasoning must rule out what specific neurological condition. Lock it in.
The answer is temporal lobe epilepsy. Auditory hallucinations point to schizophrenia, but olfactory hallucinations, smelling phantom odors, are classically associated with structural lesions or electrical seizure activity in the temporal lobe, which is located right next to the olfactory bulb.
Scenario 3. During an interview, a patient describes a sudden, severe neurological symptom, total paralysis of their right arm. However, as they describe this terrifying loss of function, they display a striking apathy, almost a cheerful indifference toward it. This presentation, known as labile indifference, is classically associated with which mechanism and disorder? Take a moment.
The answer is conversion disorder. This is a functional neurological symptom where overwhelming psychological stress is unconsciously converted into physical paralysis. The indifference occurs because the physical symptom has successfully relieved the underlying emotional anxiety. The circuit breaker has tripped.
Scenario 4. A patient sitting across from you admits they have an addiction. They recognize that their failures at work are due to their drinking, and they can articulate the damage it is causing. But they completely fail to apply this knowledge, leaving your office and immediately going to a pub. Which level of insight does this represent? Have a guess.
The answer is intellectual insight. They possess the cognitive understanding of their destructive patterns, but lack the true emotional insight required to actually alter their behavior and personality structure.
Scenario 5. You are testing abstract thinking. You ask the patient the meaning of the proverb, "People in glass houses should not throw stones." The patient looks at you and replies, "Because the stone will break the glass and ruin the house." What specific type of thinking does this failure to grasp the metaphor demonstrate?
The answer is concrete thinking. The patient is unable to conceptualize the abstract, universal moral theme of the proverb and is trapped in the literal physical properties of the words. This is a classic hallmark of schizophrenia or severe organic brain damage.
And scenario 6, a final emergency. A patient in the emergency department is frantically swatting at their arms, reporting that they can feel bugs crawling under their skin. This type of haptic or tactile hallucination formication is a massive red flag. What etiology should guide your immediate medical management? Think about it.
The answer is severe cocaine abuse or delirium tremens DTs. This sensation is caused by a hyperexcitable, misfiring nervous system, classic in severe stimulant intoxication or life-threatening alcohol withdrawal. It requires immediate emergency medical stabilization, not primary psychiatric therapy.
Excellent. We have rebuilt the map. We have seen how the raw data of a patient's life is woven into the loom of the psychiatric report. But before we finish, I want to leave you with a final provocative thought to mull over, returning to what we discussed about the psychiatric timeline.
Oh, about childhood memories.
Exactly. We learned from the text that memories before the age of 3 are almost always imagined. They are constructed by the stories others have told us, the photos we have seen, the narratives we have absorbed from our parents. It begs a profound question for anyone in this field. How much of our personal history, the very foundation of our psychiatric baseline, the anamnesis we so carefully record, is actually a factual documentary, and how much of it is a collaboratively written fiction?
That is a brilliant tension to reflect on.
If our earliest roots are stories we tell ourselves, then the psychiatric report isn't just decoding a disease, it is decoding the mythology of a person.
The subjective narrative, that mythology, is just as clinically powerful as the objective physiological fact. Both dictate behavior.
They really do.
For those looking to deepen their understanding of this process, this deep dive is a companion, not a replacement. I highly recommend returning to the source text, Chapter 7.2 of Kaplan and Sadok's Comprehensive Textbook of Psychiatry, and reviewing the sample questions provided in Table 7.2-1.
Here are the details of this episode.
The psychiatric report, an outline for a psychiatric examination. Byline. Observation becomes understanding only when it is organized into a coherent story.